Uh, so I'm going to be talking about pediatric neck masses, and this is a really broad topic, and we've learned a lot even since I was a resident about workup of different masses and treatment of neck masses. And it really is a huge topic. Typically, this is given over a series of 5 or 6 lectures to our residents on various aspects of this. So it's not going to be a comprehensive talk. We're not really going to talk about vascular anomalies, which is kind of its own separate talk as well. And the malignant aspect, the malignancies, is going to be kind of watered down a little bit just to kind of, for sake of time, as well as thyroid. But this is a very common problem that you'll see in practice if you're doing peds or if you're doing general, doing head and neck. It's a very, very common disease process that we deal with. I don't have any relevant disclosures. So in terms of outline, I think I want to give you an approach to working up a neck mass, and there's basically 3 questions that you should always ask when evaluating a child: which imaging studies to order, and then develop a framework of 3 broad categories of kind of which direction you're heading with, where you're heading with the workup of these masses, and then we'll talk about commonly seen neck masses and particularly what not to miss. And I think that's what a lot of pediatricians and parents are really concerned about, are those rare diagnoses that are potential malignancies. So as a pediatric otolaryngologist, parental anxiety over this is through the roof. It is probably one of the most anxiety-provoking diagnoses that I deal with, but at the same time, usually it's a completely normal finding. A lymph node in a child is a completely normal finding, but they may see their pediatrician. The parent may have felt something, and they go to see their pediatrician. The pediatrician isn't quite sure what it is. They look something up on the internet, and now they're convinced that their child has something very serious, potential lymphoma or sarcoma or something, and it's taken 2 weeks to get into the appointment, or a month. And over those 2 to 4 weeks, the parents are completely anxious about the diagnosis. And so I think that's really important to recognize that reassurance is a key aspect of the workup and treatment of neck masses in children. And the other thing is with anxiety is that the younger the patient is, the more anxious the parents typically are. But I'll show you some data, and we'll kind of look through the different age groups. Really, the young, early neonatal patients, there's really not much that you need to be concerned about in terms of malignancy. Whereas the teenagers, especially teenage females, they're more prone to getting thyroid cancer, they're more prone to getting lymphoma. You also see an uptick in sarcoma in that age group, but those are the patients that parents are less anxious about, but they actually should be a little bit more anxious about. And so initially, I think it's useful when you see a child and recognize that there's a differential diagnosis in each age group. And kind of think about that as they're walking through the door. And in pediatric otolaryngology, we have to think about the prenatal, neonate, infant, toddler, child, and adolescent. They're all different, and they have, and we see things at different times in these age groups. Again, so in prenatal patients, if you consult to see a prenatal patient, malignancy is very rare. Usually this is a vascular malformation or a teratoma. Those are the things that we're going to see. Vascular malformations, particularly lymphatic malformations, are much more common than teratomas. In the neonatal period, again, very rare to see a malignancy, and the most common diagnosis is going to be Fibromatosis Coli, which is, we'll get into that as well. Infant, we start to see sarcomas Hemangiomas are very common. Again, toddlers, we start to see sarcomas as well. But lymphadenopathy and abscesses become much more common as well. And then as we get in older, we start to see children presenting with congenital neck masses, which really can present at any age, but this is typically the thyroglossal duct cysts is when they kind of show up in childhood. And then branchial cleft cysts, if there's not a pit or something seen initially on the skin, that those typically show up a little bit later in adolescence. So it's important, again, to have a little bit of a framework. Okay, how old is the child? And what are we thinking about when we're working up a neck mass? Because it does vary quite a bit by age. And so again, once you've established the age and kind of a framework of the patient, I think the three questions that we should ask, and I think most of us all know this, is like, how long has it been there? Has there been any change in size? And are there any signs of inflammation or infection? Those are, I mean, they're basic questions, and I think most people would ask these questions. But I'm, often, working with residents, sometimes I'm surprised, like they may have not asked about change in size or one of these questions, which can be a key tip off to establishing diagnosis. And classifying, again, going back to kind of having a differential in your mind. I like to think of these in three broad categories. Inflammatory, which is going to be by far the most common type of neck mass that we see in children. And they're going to present with tenderness. It usually presents over days to weeks. They can be tender. They may have other signs of infection, such as fever, elevated white count, or erythema over the skin. The next big category is really congenital, which, and these are due to embryologic defects and malformations. They may manifest later in childhood, even though they're present at birth. And these typically present over months to years. Like I've had this bump in my neck, and it's been there for a few months now and it hasn't gone down. Whereas neoplasms have a different time course. They typically present from weeks to months. Chronic, persistent, solid mass is typically their presentation. And with an inadequate response to antibiotics, typically, and again, this is a presentation over weeks to months. So when they walk into your office and just the duration of their symptoms will kind of tip you off in one direction or another in terms of your differential. So imaging, okay. Imaging is very important. This is actually my grandfather and great uncle, peeking into someone's belly in Oslo, Norway, at the turn of the century, the previous century. And back then we didn't have much in terms of imaging, right? We just had to kind of like peek in there and look and open things up and take a sample and biopsy, but we don't need to do that anymore. Ultrasound is by far the most useful study for evaluating a child with a neck mass, because it can distinguish between solid and cystic. It can also distinguish between normal and pathologic lymph nodes, and we'll go over that in the next slide. And it can also be useful for doing a biopsy or draining an abscess. The problem with CT, with ultrasound, is you can't really get into the deep structures very well. So a CT scan can be helpful if you're suspecting a deep neck abscess, but really that is probably, in my practice, its only utility. It is not very helpful for working up congenital neck masses. It's not very helpful. In fact, it's completely, I find it not to be helpful at all for the workup for vascular anomalies, and really an MRI is a better study for that. So ultrasound, again, is the best study and should be the initial study for working up a neck mass in a child. And you can see on ultrasound the differences. You can see, between a pathologic and a normal lymph node. So the image here that I'm circling, so to the left here, is a normal lymph node. It is oval, kind of kidney bean shaped. It has a single pedicle of vascular flow. It doesn't have any lucencies or calcifications within the mass. It doesn't have a rind around it. So this is a normal lymph node. This can be distinguished from a pathologic lymph node. So this is rounded in shape, and it has a circumferential, it has a blood supply coming from all different directions. And within the lymph node itself, you don't really see it, but you may see other changes. You may see necrotic centers. These are all characteristics of pathologic lymph nodes. So an ultrasound can be extremely helpful, particularly when we're evaluating a lymph node in a child, because we can distinguish between normal and pathologic lymph nodes. So moving on to the inflammatory category, again, as I mentioned, lymphadenitis or a reactive lymphadenopathy is extremely common, and it is probably the most common lymph node or a neck mass that a pediatrician or an otolaryngologist will see. It occurs in 40% of infants. It can be viral or bacterial, and it is often presents as an asymptomatic or tender node. Again, this may occur over days to weeks, but they can also be there for many months or even years afterwards, after they've been exposed to something. There's also non-infectious causes of inflammatory. I guess we put them in the inflammatory category, and this is a talk in and of itself. But just be aware that there are many different non-infectious etiologies of inflammatory lymph nodes, including Kawasaki's disease and other rare things such as sarcoid, Rosai-Dorfman, which is a histiocytosis of the lymph nodes. You can get Langerhans cell histiocytosis as well, which is a different type of histiocytosis. Kikuchi, Fujimoto disease, Castleman disease, PFAPA, a little more common. But again, many different types of inflammatory conditions. Most of these are pretty rare, but that should be in your differential as well when you're working up, especially for really bulky lymphadenopathy in a child. If it's less than 2 centimeters and it's been there for a few days or weeks, and it looks normal on an ultrasound, we can be pretty assured that this is a reactive lymph node, and probably no additional workup is needed for this. So when to get concerned? So a fixed, firm mass is a concern. And it's pretty obvious on physical exam when you feel one of these. And it just takes a lot of experience. You know, the very mobile, soft, sometimes they can be slightly rubbery lymph nodes that we all feel in children feels very different than a firm fixed mass in a child. So if you feel a firm fixed mass, that is a concern. When the mass is enlarging over weeks to months, that is a concern. It shouldn't be, if you have a reactive lymph node, it shouldn't be getting bigger after a few weeks or months. It may be stable and getting smaller, but getting larger over weeks to months is really a concern. Over 2 centimeters, that's a size criteria that we use, but even many lymph nodes over 2 centimeters are completely benign. Location is not predictive. So keep this in mind. If you're feeling a lymph node in the submental area or in the postauricular area or in level 5, and it feels like a normal lymph node, it's small, it's less than 2 centimeters, you may have got an ultrasound that looks like a reactive lymph node. It is not any more likely to be malignant just because of its location than a lymph node in level 2, 3, or 4. Overlying skin changes, or obviously that can be a concern as well as a sign of inflammation. So deep neck abscess, we'll kind of go through some of these. I mean, residents know about this. This keeps them up late at night. We don't need to get into a lot of detail here, but there often can be polymicrobial. They're due to Staph aureus or group A strep. And our treatment algorithm at the University of Utah Primary Children's Hospital is we will often admit patients on antibiotics if it's less than 2 centimeters and the imaging is not convincing, such as this one here to the right. You can see it is kind of hypolucent on the CT scan, but it's really not a convincing abscess, so we would admit this patient and put them on IV antibiotics. For something that's more than 2 centimeters with convincing imaging, we'll often just go straight to surgery to drain it. Of course, there's all those patients in the group in between who are not totally convincing. There's a big gray area here. I certainly recognize that. And that's, I guess, where clinical judgment comes into play. If we're admitting someone with IV antibiotics, we will reassess after 24 to 72 hours and reconsider our plan. Just a note here on atypical mycobacterium, which is also a type of deep neck abscess. We see a lot of this in Utah. I'm not sure, it seems to have a geographic predilection, but it's very classic. It seems to be very common in the upper cervical or submandibular nodes. You can see the violaceous skin changes, and this really occurs over months. It may present as a small lymph node and then just progressively getting bigger, and then eventually you have overlying skin changes. It often is very intimate with the facial nerve in this location, making complete surgical excision challenging and potentially morbid. But surgical excision really is the preferred treatment if you can do it safely with low morbidity. Alternatively, you can treat with rifampin and azithromycin, but this may take 3 to 6 months, and maybe only 2/3 of those will actually respond. If they're having disseminated disease, obviously they need to be worked up for other immunodeficiencies, including HIV. So Kawasaki's disease, again, another big inflammatory condition. This is something you have to know about as an otolaryngologist. And it's interesting now with what's happening with COVID and all these cases of Kawasaki's disease. We don't really know what causes Kawasaki's disease, but even 30 years ago, it was suspected that this was due to coronavirus, but it was never really proven. And now we're seeing in an older age group, this multi-system inflammatory condition with similar symptoms, which I think is additional evidence that this is likely virally related. So to have Kawasaki disease, you need to have an unexplained fever, high fever, typically over 103, for 5 days with 4 of the 5 following conditions. You have to have changes in your extremities, so erythema and edema. You can also have this membranous desquamation at the fingertips. You need to have polymorphous exanthema. So this is a painless bulbar conjunct. Number 3 is a painless conjunctival injection. So they have really red eyes, basically. They usually don't have an exudate with it. And then they can have these changes on their lips and oral cavity as well. This erythema, strawberry tongue. You can see these cracking of lips, very red lips, as well as enlarged lymph nodes greater than 1.5 centimeters. Usually it's unilateral. So to really have a classic diagnosis, having the classic characteristics, classic symptoms of Kawasaki disease, you need to have 4 of these 5 conditions. But many patients do not have all of those conditions. And here's some example. This is the strawberry tongue, exanthema. This is the changes on the lips and hands. These are not my patients. These were downloaded from the website shown below. But many patients have a kind of an atypical presentation of Kawasaki's disease. And I think if you have a child who has an unexplained fever for 5 days, the other thing that's not on here that we often see with this is just this irritability. Like the patients are just angry and they're unconsolable. And they have this fever for 4 or 5 days. And they may have some mild rashes, or they may not have all of these features, these classic features. You have to think about Kawasaki's disease because the alternative to missing this diagnosis can be pretty severe. So, which includes coronary artery aneurysms. So we have a low threshold to call them atypical Kawasaki's disease, and I think if we have no other explanation for their fevers, they get treated with IVIG. So those are kind of, again, those are the broad categories of inflammatory conditions that these are things that you really can't miss as an otolaryngologist. That, you know, Kawasaki's disease, atypical mycobacterium, and then just the deep neck abscesses. And again, as I mentioned before, there are many, many different inflammatory conditions that it's beyond the scope of this talk to really get into too much detail about it. But if you do a lot of this in your practice, you will see these conditions as well. So congenital neck masses, and these are embryologic defects, and not all of them, but they typically are. And we'll go through some of these conditions, but it's a very long list of different conditions that we see, and they show up at different age groups as well. Vascular anomalies is a big topic in and of itself. We're not going to really get too much into that as well. That usually requires 2 or 3 lectures just to kind of give a basic introduction. So Fibromatosis coli. This presents in the first few weeks of life, and it can be very anxiety provoking for families because they have their newborn baby, everything's going great, mom or dad feels something, there's this hard, and the thing that's scary about this is this is a hard fixed mass in the sternocleidomastoid muscle. Pediatrician may or may not know about this. It gets very concerning. I've gotten urgent consults, in the middle, usually in the middle of the night, but very panicked pediatricians and parents about this. But again, just from the time course itself and the age, we know that this is not likely a malignancy because it's presenting in the neonatal period, and malignancies are extremely unusual in the neonatal period. I don't think there's even been a reported case that I'm aware of sarcoma before the age of 6 months. And this is thought to be due to a vascular accident in the sternocleidomastoid muscle, causing scar tissue, a kind of a ball of scar tissue to form in the muscle itself. They involute on their own. It has pathognomonic features on ultrasound, which is basically a lucency on ultrasound in the muscle itself. Really, most of these resolve. Some of them may present with torticollis and they may need physical therapy, but they don't generally need to be biopsied because of just its presentation and ultrasound findings. So branchial cleft anomalies, I think residents know about these. I'm not going to get into too much detail about this. This is something that is a classic question on the in-service exams. You can have, I think branchial cleft anomaly is a better term than whether it's a true branchial cleft or if it's a fistula, a sinus, or a cyst. They kind of encompass the broad category of branchial cleft anomalies, and this has to do with the development of the structures in the jaw, ear, and neck. And as the embryonic fusion planes, if there's a failure to completely fuse, you can have these anomalies. So classically, the first are associated with the ear canal and can be intimately involved with the facial nerve. Second, anomalies or cysts generally track up to the tonsillar fossa. And third, can involve the thyroid gland itself. Fourth, branchial cleft anomalies, I've never seen one. To me, it's kind of like Bigfoot. Like I've seen some fuzzy photos of them, but I've never seen one. Theoretically, this should go into the chest and wrap around the aorta and go back up into the neck to be a true fourth branchial cleft anomaly. I've never seen one. I've never really seen a convincing report of one. Keep in mind that just because there's a pit overlying the chest, or there's a pit that we see that is very low, does not necessarily make that, doesn't determine whether it is a first, second, third, or fourth branchial cleft anomaly, because you can get pits, and we'll talk about this a little bit, which is an epidermal inclusion cyst. You can get epidermal inclusion cysts anywhere on your body, and it doesn't necessarily mean that it's a branchial cleft anomaly. Obviously, the ones that are close to the ear canal are going to be firsts, but along the neck itself, the position of the pit is not determinant of what type of branchial cleft anomaly it is. So again, third, these are rare, and they can involve the thyroid gland, and they can lead to an abscess within the thyroid gland. It's more common on the left side. And there may be an internal opening in the piriform sinus. These are also called piriform sinus fistulas. This may or may not be related to a branchial arch, but the treatment for these has changed in my practice over the last decade or so. I used to go in and remove the cyst and do a hemithyroidectomy often when the patient has had infections and there's a lot of scar tissue. But if you can identify that opening into the piriform sinus, you can take a Bugby catheter and just zap that, and that will kind of get that to scar down, and the abscess will resolve. And that's been my preferred method of treatment for these over the last few years, and I really haven't had to do a thyroidectomy on these patients. Thank goodness, with that technique that was described out of Seattle. Thymic cysts also can occur in the central neck in a similar location, and they have they're often more commonly seen in the chest, but they can occur in the neck as well. They often present as neonates, and they can be quite large in the chest, and they may present with respiratory symptoms. But this has to do with the descent of the thymic gland into the chest during development. Here is a CT scan, kind of a fuzzy CT scan, not a great scan of a thymic cyst in the chest right here. Along with in the congenital category, thyroglossal duct cyst, residents know all about this as well. I'm not going to spend too much time on this. But a thyroglossal duct cyst, just to remind you, the thyroid gland starts at the junction between the posterior tongue and the anterior tongue, the foramen cecum, and it descends into the neck. And you have a remnant of that descent is the pyramidal lobe of the thyroid gland. And anywhere along there, you can have this tract that can form a cyst. And you have to remove the entire tract, and including extending and dissecting up to the base of the tongue to completely take care of this problem. And just keep in mind that ectopic thyroid tissue can be present in the thyroid gland. And you can see that here. This is how they present. This is a kind of midline neck mass in this child, centrally very midline in location. And again, it can be anywhere from the base of the tongue all the way down towards the thyroid gland. It elevates with tongue profusion, and generally the preoperative workup for this is simply an ultrasound. And also it's important to look at the thyroid gland itself to make sure they have a normal thyroid tissue. I don't do any thyroid labs if they have a normal looking thyroid gland. And I usually don't do any additional imaging besides an ultrasound. So here, it shows you, this is ectopic thyroid. This is a neonate who presented with respiratory distress, and you see this ectopic thyroid tissue at the base of the tongue. This was the patient's only functioning thyroid gland. And you can see with this associated cyst way up in the base of the tongue, this is an associated, we call these follicular cysts when they're isolated, but really this is a manifestation of a thyroglossal duct cyst at the base of the tongue and causing airway obstruction. So associated, very similar, is a Forgut duplication cyst. And the difference really is on histology, because you see epithelium and smooth muscle on histology. You wouldn't see that on a thyroglossal duct cyst. You would see on a thyroglossal duct cyst, you would see respiratory epithelium and thyroid tissue. But this has to do, they're actually more common in the mediastinum. They can occur anywhere along the midline, and this has to do with the as the Forgut separates into the respiratory and into the digestive system, you can have a cyst develop there, and typically midline, and can be anywhere from the tongue all the way down into the chest. And this would have, again, smooth muscle in it, distinguished from a dermoid because it has smooth muscle, whereas a dermoid would just have epithelium, squamous epithelium. So again, epidermoids and dermoids. This is an embryonic fusion plane problem. You can see this here in the palate. They're often very common here behind the ear as well. You can see them in the tongue. You can see them in the midline neck as well. It is the second most common congenital neck mass in the midline neck. And this patient here, who has a thyroglossal duct cyst, this could, you know, until you take it out, you don't really know for sure what it is, because this could very well be a dermoid cyst as well. The difference on imaging is that a thyroglossal duct cyst often has a complex cystic mass, and a dermoid is a simple, it doesn't have septations, it's very round, and but it also is midline, like the thyroglossal duct cyst. So, and when as we're talking about epidermoids and dermoids, I think it's important also to talk about teratomas, which are extraordinarily rare. And they often present in the prenatal period, but they're related to epidermoids and dermoids and teratomas. They're often in the same paragraph in the textbook chapter on congenital neck masses. But the behavior is very different, and the treatment, these can be quite serious because they can be very large, they can block the airway. They often originate near the thyroid gland, and this is a solid tumor. They have all three germ layers in them, whereas a dermoid just has epithelium in it, and they have a very high mortality due to if something is not done at the time of before they're delivered, because their airway is completely blocked off. So they need exit procedure, which is a way to extrapartum intrauterine therapy, which is a way to establish the airway before they're removed from maternal fetal circulation. There's two types of these. There's mature and immature types, and they are followed differently. The immature forms have a slightly higher risk of malignant transformation and have a higher risk of recurrence and need to be followed carefully. So here, this is an example of an exit procedure. This is a teratoma coming off of the palate, and we're establishing an airway. We had to remove the teratoma before we could establish an airway. Here's another patient who underwent a tracheostomy. We couldn't remove this At the time of the exit, we had to just kind of move the tumor out of the way and place a trach here, a low trach, to establish an airway. You can see how big these can be and how it displays the normal structures. This is the carotid artery kind of being splayed away. It's important to really get into a very deep plane here because the capsule of these often contains critical structures such as nerves and blood vessels. So you really want to be in a very deep plane when you're taking these out. They can also have these a lot of these septations in them that hide important structures, and you have to really dissect that out very deep to the tumor itself and preserve as much tissue as you possibly can. So here's the patient afterwards. After it's been removed, you can see how like these are just basically normal kids, and they just have this mass there, and if you can remove it, they can have an excellent outcome. The patient that I took care of from Africa who came to see me in Utah had it somehow, like I said, mentioned that it has an 80% mortality if you do nothing. And you know, this patient had a completely deviated airway, but somehow survived. And I was quite impressed with this, that this 2.5-year-old female was just walking around with this large teratoma that we ended up resecting. They came to Utah for that. And she's doing great back in Sierra Leone. So not all patients, you know, some patients do survive with these teratomas, and somehow they can, you know, live for years with it without intervention. So that's kind of the introduction talk on benign neoplasms, congenital neck masses, lymphadenopathy. Those are the kind of the big, broad categories. There aren't really any solid tumors that are benign besides hemangiomas. As I mentioned, we're not going to really talk much about hemangiomas because it's kind of a separate talk in and of itself. So when we're talking about solid tumors, and they're not in the age group where we ruled out a hemangioma, we start to get concerned. And these are the common malignant neoplasms that we see in children. We see lymphoma is very common. Sarcoma is the second most common malignancy, and followed by thyroid carcinoma. Occasionally we see salivary gland neoplasms. We can also see metastatic disease from other locations as well as melanoma. So again, we're going to go back to that chart that we talked about, that was showed at the beginning of the lecture series. And remember, malignancy, very rare in the prenatal period, and also very rare in the neonatal period. As you become an infant and toddler, sarcoma becomes more common. As you become a child, we start to see lymphoma. As you become an adolescent, you start to see thyroid carcinoma as well. Thyroid cancer, unless they have a genetic predisposition, such as an MEN syndrome, or it's uncommon under the age of 12, but we certainly do see it. So here's an example. I told you that it's very rare to have a malignancy, and here's the exception. This was a prenatal consult, a vascular tumor diagnosed prenatally. We planned for an exit, but really didn't need to do an exit. The patient was delivered fine without problems. It was breathing fine, didn't have to do any intervention, but you can see this highly vascular tumor in this infant. This was a CT angiogram that was performed postnatally. We performed an incisional biopsy, and it showed this atypical melanocytic proliferation. We thought this was benign. We showed it to people all over the country, including Dr. Fletcher at Dana-Farber, and who agreed that this is just an atypical melanocytic proliferation. They usually resolve on their own, And since it was so vascular, we decided to hold off on resecting it right away because of its vascularity and risk of blood loss. Well, around 19 months, it started to grow, and it became quite large just over a period of a few months. And so we went and excised it, and it had undergone malignant transformation. So technically not malignant at birth because it had transformed, but this atypical melanocytic proliferation turned into invasive melanoma. The family had genetic predisposition for this that we discovered later. And fortunately, the patient was put on a biologic. She is now just turned 6 years old and is disease-free, but she did have positive margins because it was involving the dura. She also had pulmonary metastases, but none of that is detectable now, and she is doing well on a biologic. So lymphoma, this is the most common malignancy that we encounter in the head and neck. It occurs for about 55 to 60% of all pediatric malignancies in the head and neck. And the incidence increases with the age of the child. Typically presents as an asymptomatic, unilateral, hard, firm neck mass. And again, Hodgkin's disease is the most common in the head and neck. Very important to evaluate for shortness of breath, to get a chest x-ray or to get a CT scan of the chest if you're suspecting lymphoma, because if they have mediastinal involvement and you put them under anesthesia, they can have a severe superior vena cava compression syndrome, where as you put them to sleep, their venous structures can be compressed and they can go into cardiac failure. It's always controversial about, should you do an FNA, should you do an excisional biopsy? Generally, if I'm strongly suspicious that this is a lymphoma, I'll just go right to an excisional biopsy because that's what the oncologists want. And getting an FNA often just leads to a delay in diagnosis. Now, with that said, I don't do a lot of excisional biopsies on lymph nodes in children that are reactive in nature, and I have very low suspicion that it's malignancy. But if I have a teenager, it's a firm fixed mass, it's been getting larger over weeks to months, and particularly if they have B symptoms, which they often don't, I would likely just go straight to an excisional biopsy. And again, the importance of assessing the mediastinum. This is a patient with mediastinal lymphoma. It's compressing, in this case, it's compressing the trachea as well. But this is obviously very high risk for anesthesia. You'd want to know about this before you put them under anesthesia. So you'd always want to either get a chest x-ray or a chest CT to look at the chest before putting them under anesthesia. So sarcoma. Sarcomas are the second most common malignancies in the head and neck, according to a Sears database. I kind of, when I looked that up, I kind of found that really hard to believe. I would think that thyroid carcinoma is much more common in children. But this can occur anywhere in the head and neck. And we separate them into different categories, into embryonal or alveolar, and that has to do with how immature the cells look on histology. So embryonal rhabdomyosarcoma, they're kind of plump, round cells, look immature. They're dividing rapidly, and they're more responsive because of that to chemotherapy because they're dividing. The alveolar are a little bit more mature, and they're dividing less frequently, and they're a little bit less responsive to chemotherapy, and their prognosis is worse. So that histology does have implications on their outcome. Parameningeal versus non-parameningeal, it's spelled incorrectly, I'm noticing, but that has to do with its relationship to the skull base and meninges. Parameningeal locations have a worse outcome than non-parameningeal. If you have a sarcoma in the long bone and you can cut this out completely, they do not need radiation therapy. They can do chemo and have surgery and they're done with it. But in the parameningeal location, if it's involving the skull base, if it's involving multiple critical structures, you cannot remove that completely. And so they often need radiation and chemotherapy, and outcomes are worse because of that. So here is a graph to kind of to show what happens with rhabdomyosarcoma. You can see really we don't see at birth, we don't really have any in this series, no reported cases of children developing rhabdomyosarcoma before 6 months of age. And this is the alveolar, which is kind of like the orange. It's kind of like it shows up pretty much at any age group, starting at 6 months of age all the way to age 19. The embryonal is the red, and we see a big uptick around starting around 6 months of age, and with a peak around age 3.5, 4, and then it slowly goes down, and then we see another bump up here later, beginning at age 12. There's another this bimodal distribution. We see another uptick here in adolescence. So overall, if you look at both, you can see that there's higher incidence in young age, it goes down, and then again, another bimodal distribution later. That's mainly due to an embryonal, the bimodal distribution of embryonal rhabdomyosarcoma. So this is why it's very important to be, if you combine this with the lymphoma data, you can see that, and the thyroid data, you can see for cancers in general, it is much more common in adolescence than it is in young infancies, in toddlers. I mean, obviously we want to be concerned about thyroid with malignancies in toddlers as well, but again, later in adolescence, we need to have that high index of suspicion, particularly in teenage females, for thyroid cancer, lymphoma, and sarcoma. So thyroid cancer, again, this is just a very brief overview. We're not getting into, this is a whole series of lectures in and of itself. You really can't adequately cover this topic just in a 1 hour talk on neck masses, but it's important to talk about this because this is one of the third most common malignancies in children. And much more common in age 10, over age 10, more common in females. Under the age of 10, it is more common in males. And the workup for thyroid cancer is different in children than it is in adults. And that has to do with the incidence of nodules in children in general. So it's unusual for a child to have a nodule. And if they do have a nodule, the chance of it being malignant is much higher than it is in adult. If you look at in adults, if you have a greater than 1 centimeter solid nodule in the thyroid gland, that has a 5 to 10% chance of being malignant. Whereas in a child, it can be 25 to 50% chance because nodules are just less common in children. In adults, we have size criteria for biopsy of nodules because we don't want to over biopsy, and we don't, and that just leads to unnecessary surgery because when we biopsy, we don't always get a perfect answer. We often get this intermediate answer that says, well, it's unspecified whether this is malignant or not, and so that could lead to additional surgery. And so we have size criteria to avoid doing too many biopsies on patients. in children, there are no size criteria, really. The American Thyroid Association, does not have a size criteria for biopsy. So any solid mass, solid nodule in a child should be biopsied because again, nodules are unusual. Why would a 6-year-old have a nodule in their thyroid gland? That's unusual. Something's going on there. This is not typical, physiology that we see in adults. And so if it's 8 millimeters and you have a child with a solid nodule, it needs to be biopsied. The other major difference is that in adults, hot nodules, that means that they are avid uptakes of iodine, reactive iodine, those are thought to be benign. Those are thought to be adenomas, and they're benign, and they don't need to be, that gives us reassurance that this is not malignant. The opposite is true in children. A hot nodule in a child is malignant until proven otherwise. And so that does need to be worked up more. And that is concerning. I don't order uptake studies in my workup of neck masses, but endocrinologists often do, particularly pediatric endocrinologists. And so if you see a hot nodule that's been worked up by a pediatric endocrinologist, then that is concerning. That needs to be biopsied, and particularly regardless of size, but that's true for any nodule. For solid nodules, again, we're not talking about cysts within the thyroid gland, but solid nodules warrant a biopsy. And again, there's no size criteria by the American Thyroid Association, but there is obviously a technical, there's a point where you just can't biopsy because it's too small. And so that has to do with the expertise of your local institution. So the other thing to keep in mind with children is that they present with more advanced disease. Their prognosis is excellent, and by definition, they can never be more than a stage 2 because of age criteria. Anyone under the age of 40 cannot be more than a stage 2 because age is built into the staging system. So they have a very good prognosis, even with pulmonary mets, which I've seen as young as age 2. We kind of watch those. They typically remain stable. It typically doesn't lead to any significant disease, although it's very concerning to parents and caregivers. They have a upper 90% chance, 97, 98% chance of dying of something else besides thyroid disease in their lifetime. And the workup for thyroid carcinoma, as everyone knows, again, ultrasound is the diagnostic test. So when you order an ultrasound, I always get lymph node mapping if there's a suspected mass in the thyroid gland as well, because you want to look carefully at the central compartment and both lateral compartments. And so the ultrasound ideally should be done by someone who does a lot of ultrasounds on the thyroid. Many adult otolaryngologists, head and neck surgeons, do their own thyroid ultrasounds because thyroid carcinoma is rare, and they often present with advanced disease, and we need to look at their lymph nodes carefully. I don't do my own ultrasounds. I have an adult endocrinologist do it, who I work with, who has more experience than the pediatric otolaryngologist when it comes to cancer. I also have at the children's hospital, if they need to be sedated, we have the interventional radiologists do that as well. So really important to look at all of the lymph nodes when working up thyroid cancer in children. So other considerations, so MEN2A and 2B, we kind of know about those patients already because it's familial, autosomal dominant, and they have a high risk of medullary thyroid carcinoma, and there are guidelines for prophylactic thyroidectomy as young as age 1 in MEN2B. It can be pushed out a little bit longer in MEN2A. But it is getting very specific in terms of their mutation, depending on the type of mutation that they have. The guidelines recommend waiting, observation, checking calcitonin levels. So this is getting very personalized in terms of its approach to patients. Those patients should be screened for RET, proto-oncogene. P10 hamartoma syndrome also is another genetic consideration in children. This is Cowden syndrome. But now we know what the genetic mutation is, which is P10. And those patients present with developmental delay often. They have autism or mild developmental delay with macrocephaly, and they can get hamartomas all over their body. Later in life, because they are at risk for malignancies and need to be screened, they need to be seen in a high-risk cancer center. In childhood, they typically don't develop cancers, but they can develop a thyroid goiter. The risk of thyroid cancer is slightly elevated above the general population. Most of them have large goiters that are followed. Some of them have to be removed if they're large and obstructive, but and it's recommended that these patients with P10 hamartoma syndrome have an annual ultrasound as well. So resources for neck masses, fetal center for the teratomas. Thyroid disease really needs a pediatric thyroid team with it, which would include a surgeon, pediatric endocrinology. Often will bring in adult endocrinologists who have more experience with cancer. Vascular anomalies, which we really didn't talk about in this talk, but that also, those patients often benefit from being seen in a vascular anomalies center. So in summary, we'll give time for questions if there are any. We're just kind of finishing up right now. Often the history and patient age will give you the diagnosis. Ultrasound is the best imaging study in almost all cases when working up a neck mass. Rhabdomyosarcoma is the most common pediatric sarcoma with a bimodal incidence. Thyroid carcinoma and lymphoma are seen in older children and adolescents, and again, maintain a high index of suspicion in adolescent patients. And that is the conclusion of my talk. I'll see how much time we have here. We have a few minutes. Open it up to any questions. Okay, well, I'm going to go ahead and sign off at this point, and it was a pleasure to participate in this series. I hope that it is useful to the residents, and again, thank you for letting me present.
Thank you, Dr. Grimmer. We really appreciate it.
Yeah.
Did you see this one question? It said, have you seen any cases of the COVID inflammatory process in kids?
I didn't see that. That's a good question. So I saw a patient recently who had bulky lymphadenopathy. Can you hear me? Mm-hmm. And they had macrophages within their lymph nodes. And we got infectious disease, and the thought was maybe this is macrophage activation that we see in COVID in this inflammatory condition, but the serology was negative. so no, I haven't seen it in terms of presenting as a neck mass. Utah has been spared relatively with COVID. We've only had 3 actual pediatric patients treated at our children's hospital for COVID. And we see maybe the most at our peak was 200 cases a day in the adult population. So fortunately, we've been relatively spared. And I haven't seen I'm not even aware of the multi-inflammatory disease that they report in Italy. We haven't seen that in Utah. Have you seen that in Kentucky?
Haven't. Not that I know of anyway.
Okay, let's see, any other questions here? So yeah, I mean, theoretically, with that macrophage activation, it could present as a neck mass, in theory, but I haven't seen it reported or seen it myself.
Well, thank you very much.
Okay.
Again, thank you for your support.
You bet.
We'll have this recorded, so we'll have it edited and up on the website tomorrow morning.
Great. All right. Thanks again for letting me present.
Thank you.
At this point.